Welcome, everybody. Thank you for joining us today for MVC's Health and Action Workgroup presentation. My name is Rachel, and I am a Site Engagement Coordinator with MVC. It's my pleasure to be facilitating this workgroup for you today. On our agenda today, we're going to be going over some housekeeping and P4P credit reminders. We'll do a little introduction to our presenter. Then our presenter will be presenting on the Community Paramedicine program. That'll be followed by some questions and also some discussion questions that we've come up with for you guys. And then we'll go through some of our upcoming work groups and events with MVC. So some of our housekeeping items, just a reminder that this session is being recorded. The slides and the recording will be shared with attendees following the work group. Also, just remember to mute yourself during the presentation. That way it helps reduce any background noise or anything like that. You're always welcome to unmute yourself if you have a question throughout the discussion portion of the presentation. We will also be monitoring the questions that come through on the chat. So feel free to send those through as the presenter is speaking, and we'll definitely go through those during the question and answer portion. For those that are attending the work group for P4P credit, we look forward to your active participation throughout the work group. This includes responding to the discussion questions that will be towards the end, and then asking any questions that you might have following the presentation. And then just a note that the post-work group survey will be, a link will be shared at the end of the entire presentation in the chat. And if you are hoping to get P4P credit for attending this work group, you will want to fill out that survey and send that in. And just a reminder that only one person fills out a survey for one site. So keep that in mind as you're doing that. Moving on to introduce our presenter. Today we're joined by Amanda Biskner. She is the Community Paramedicine Coordinator for Tri-Hospital EMS in St. Clair County. Her career in EMS began in 2010, achieving paramedic licensure in 2012. Her background consists of critical care transport, emergency out-of-hospital medicine, med-surg cardiovascular intensive care, correctional nursing, home health care, community paramedicine, EMS management, and EMS and public health education and public relations. In 2019, she graduated from St. Clair County Community College with her associate's degree in nursing and is in the process of completing the requirements for her bachelor's degree. She is also presented for the Michigan State Rural Health Conference on monoclonal antibody infusion therapy, highlighting St. Clair County's involvement and the THEMS monoclonal antibody infusion program. Outside of medicine, she enjoys scuba diving, traveling, reading, and spending quality time with friends and family. And with that, I'm going to pass the baton over to Amanda to begin the presentation.
Oh, you're muted, Amanda. Sorry.
There you go.
Now.
You're good.
I don't have to say much about myself, so thank you very much. So this is going to be a very brief overview of community paramedicine. It is a very in-depth topic, but I'm no expert by any means, but within the last 3 years, I've done so much research. And I hope that these tips will generate some questions in the end, because it is a fairly new topic, but it's something that I really enjoy talking about. There it is. So what is community paramedicine? Community paramedicine, it has many definitions, but the one that I like to use the most, it is very holistic in nature. So the idea of it is that it takes care of the whole person. It's very patient-centered, And it's utilized to bridge the gaps in a healthcare system, whatever those gaps may be. And we'll discuss how you isolate that and find those gaps in your community a little bit later. Overall, this concept has been around for roughly 40 years. There are many programs all over the world, all over the United States. There's approximately 100 agencies in 33 states that have some version of community paramedicine. So we're trying to get St. Clair County where it needs to be. We're a little behind. The origin of the term community paramedicine is something I get asked a lot. Where did it come from and why is it called that? In 2001, there was a model for improving healthcare delivery in very rural communities. And this idea became what we know as community paramedicine today, utilizing paramedics that have extensive education and background that maybe weren't as busy while on duty in those rural communities. And the idea became, well, why don't we go and do home visits and check on these patients and see how they're doing, and not only deliver that continuing of care to them, but prevent the readmission or exacerbation requiring hospital admission. So that's where it came from. So this slide is very important to me, especially going through and changing how patients and how the community views EMS. We have always said we're pre-hospital care, which to me insinuates that the care that we give on scene is eventually going to end up in a hospital or being transferred. Out of hospital care is the term that you will start to hear. We're really trying to change the terminology because out of hospital care means so much more and it identifies us better. Especially when it comes to community paramedicine, treating in the home, on scene, and we might not have to go anywhere else. We're keeping those patients at home where they actually want to be. So this slide, I don't know if anyone in the audience is familiar with either term, but there are many agencies that utilize these terms interchangeably, and they're actually not the same. So the most vibrant definition of community paramedicine and the difference it has with MIH is the amount of education that it requires for the providers that are going to be out there and doing CP. It also has the ability to interface with the 911 system. So in order to have a community paramedicine program, it has to be done by an ALS licensed agency. It has to be done in a vehicle that is licensed as ALS. So for us, it's an echo unit. So I'm fully equipped as an ambulance would be, minus that transport aspect. And then I just have a few other fun tools for community paramedicine. Mobile integrated health is more hospital-based. You will notice that it's a more focused education. So quite often a program will launch that is MIH specific in CHF or in COPD. And so the knowledge they have is tailored specifically to the population of patients that they are going to see. It's not a licensure, and to my knowledge, there is no plans to license MIH as as an additional certification. There is plans in the works to do that for CP. So it is the hope that eventually it will be an additional licensure to a paramedic. Right now, it's just a special study in Michigan. It requires extensive education in multiple different areas. So the idea behind this is it's not just chronic disease or acute on chronic exacerbations that we're learning about. It goes well past the traditional scope of practice of what a paramedic would be familiar with. So it's home safety assessments, it's fall risk safety, it is pharmacology-based, infection prevention, wound care, which paramedics don't traditionally see anything in wound care. So that education is a lot more diverse and more extensive when you're looking into community paramedicine. So every community is very unique. And this goes without saying. Community paramedicine might not work in every community. It's not a fix-all for anything by any means, but it can help. Um, a lot of what I have seen in my research that ends up creating a program similar to this is they need an increase in public education. There's just that lack of medical literacy. Um, when it comes to medications, patients really don't understand. They might just say, I take it because my doctor tells me to, or, my daughter harps on me, so I take these medications. Um, we know that that's really not a good enough explanation, but that's all they know to that. Medication adherence. There's so many patients, especially when we're looking at these chronic illnesses, that just don't take their medications. And that can be for many different reasons. Chronic disease education and management, especially with the COPD and CHF population, so much information is thrown at them when that diagnosis is new. And by the time they get home, they're so confused, so overwhelmed. They don't know what questions to ask. And being able to go into the home when they're in their own environment, it helps relax them enough to ask these questions, and they don't feel as embarrassed. Facilitating transportation, sometimes that's all it is. They just don't have the ability to get to their appointments that they have scheduled. It's not necessarily an adherence to appointment issue. They just don't have any means of assistance. And so sometimes I end up coordinating that, and it fixes the adherence issue. Community resource referral is huge. To know what's in your community and what's available. A lot of patients, they don't know where to find that information, or they're embarrassed to ask. So creating this program was a lot of research as to what is available in my community that can do simple things like Meal on Wheels, provide those meals that maybe the elderly aren't getting. Where can I go to get a walker or a cane or a shower chair, grab bar assistance? How can we build a ramp for you that, makes things safer for you? Gathering all of that information is huge, and being able to provide that when it's needed. Reduction in loneliness for the elderly. I think this goes without saying, but this is single-handedly why my visits take a little bit longer sometimes than they should, because they want someone to talk to. They want someone to have coffee with, and I think that this ties into that holistic nature of what community paramedicine can do. You would be amazed what a cup of coffee and a 20-minute conversation can do for somebody. And that's what we're here for. So this is a question that I get asked very frequently. How does community paramedicine differ from home health care? And there are many differences, and this is just to plant the seed for a few. When it comes to community paramedicine, it's more of an acute, subacute care mindset. This is not a permanent solution to any of the difficulties that a person may have. This is not a 6-month visit regimen when they should be going to a skilled nursing facility. What's nice about community paramedicine is that not only do you have to be a paramedic in order to be a community paramedic already, but that mindset is there for emergent situations. So some of the staff that is in home health care, they don't have any emergency background whatsoever. Whereas the paramedics that you'll often see get involved in community paramedicine are senior paramedics with, 10 or more years of experience. They're very well versed in having to adapt to any situation at any time. So should our very non-specific visit turn into an emergent situation, which has happened, we just turn into paramedics and we follow what we normally would do. It is directly integrated with the 911 system. As I mentioned earlier, we have the capability of utilizing what's in our vehicles to treat the emergency right then. and then call for the ambulance. So it's not like we're just sitting there, waiting for the ambulance. We can actually initiate that care and get that moving before we bring in the ambulance for transportation, heaven forbid if that is needed. And then being able to utilize our EMS protocols as paramedics, as well as the community paramedicine protocols from the state of Michigan. Every state is a little bit different when it comes to their protocols and their programs, so I really can only speak to Michigan. But I, for almost anything, am able to use what I have in protocol as a paramedic to treat a patient on scene before I ever need to contact for further orders. Home health care, their main focus is on chronic care. Not always, but mostly. They deal a lot with wound care, wound vacs, central lines. There are some community paramedicine programs that have extensive education in that because that's what their specific community needed at the time. But ours is not one of them. So we utilize our home health care a lot for that knowledge because they're very intelligent folks when it comes to that. They can't provide most treatments on scene without an order. So sometimes we're on scene waiting some extensive time to get a hold of a physician and ask them, if we can give a medication that might really make a difference, such as IV Lasix. They don't have the ability to just start the line and give the fluid and give the medication, whereas in certain situations, I do have that. They don't perform EKGs or EKG 12 leads unseen unless that's ordered by the physician, and they don't usually have IV supplies to even go forth and do that if it is ordered. So those are some barriers to home health care, unfortunately, that as a paramedic, I'm easy to overcome with that. And then the scheduling for home health care, it doesn't seem to be as flexible as what community paramedicine is. So I can adapt my schedule for patients based on what they need specifically. If they need to be seen once a week, twice a week, 3 times a week, even because of what's going on, I'm able to do that. And sometimes home care agencies, being so overloaded with patients, they struggle with that. So we often collaborate care together instead of looking at each other like a duplication. Our home care agencies in this community have been wonderful when it comes to bringing this program forward. So step one for anybody that is curious if community paramedicine would work in their community is to identify the need in that community specifically. Our St. Clair County Community Health Improvement Plan, they have been very valuable. They do a community needs assessment and update it every 3 years. So this data was published, or it was collected, I should say, in 2021. It was published in 2022. And then I had the pleasure of being a part of the improvement plan and selecting these 6 priorities within our community that could benefit the most from some significant attention. We already have some programs in the works for the first 4. So ironically, chronic disease and the access to healthcare providers and services fit right into what we were trying to do here. And it takes away, if we already have some services, we don't need to duplicate those services. So there weren't a lot of attention to the last 2 there. They really wanted to focus on the top 3. So I helped out with the last 2. So after the foundation of the program was built, you get to a point where you can only learn if you jump off the cliff. So that's what we did. We decided to launch a community paramedicine trial, and it was launched on the 19th of June and went until October 30th of last year. And we'll get into some of the data about it. But these were the goals that I set for with my team from McLaren Port Huron to really hone in on trial patient selection. So, increasing that effective communication between the healthcare team as a whole is huge for community paramedicine success, but also for patient care. Getting their physicians, their nurses, their social workers, their pharmacy to all talk to each other so we know what's going on, it's a challenge. But it's better for the patient ultimately. And so that's something that we really wanted to work towards. Increasing the access to healthcare for underserved populations. Medicaid, and we'll talk about this in just a little bit, but Medicaid happens to be one of the insurance providers that do cover community paramedicine services. So we've really been able to hone in on that population and provide them what they need in the community to be a success, whereas they might not be able to afford other options. Improving patient satisfaction and quality of life. Community paramedicine isn't just about having a patient that they follow a care plan with you for, a month, 2 months, and then discharging them. If you take a patient that isn't doing very well and should have been on hospice all along, but won't have that conversation with anyone, quite often they will with me. We're able to form that rapport and they feel like they can, trust what I'm saying. And I had a patient that refused on multiple occasions to even talk about hospice. And then eventually we were able to transition that care over where she truly needed to be in the healthcare system. And that was considered a win. So the other one is improving the patient care experience between the transitions. So from hospital to home to skilled nursing facility, back home. Sometimes patients get lost in the middle at no fault of anyone else, but it happens. And so recently, we have tried to collect data on patients that leave the hospital, go to a skilled nursing facility, and then perhaps get discharged a little bit too early and end up going home and then readmitted. So we're trying to see where community paramedicine can fit there to help with that transition going back home. So the patient qualifiers that we set up for the trial, and they stand true for right now. Diagnosis, we've really wanted to focus on CHF, COPD, AMI, diabetes, and I really didn't see many sepsis patients, even though that was a qualifier. I'm certain all across the nation, these diagnoses are not foreign to anyone. This is the population that has extensive comorbidities and lots of other things going on, med compliance issues, frequent readmissions. So these were the patients that we were definitely going to target to see if we could mitigate some of that. The insurances that will cover my services right now for community paramedicine, Blue Cross Blue Shield, Medicaid, they do pay for this. Medicare Plus Blue and Medicare, or I apologize, Blue Cross Advantage plans have now provided some payment for community paramedicine as well. The one that does not, and I think really should, is Medicare. A lot of that population could benefit so greatly from community paramedicine, and unfortunately, we're not there yet. Myself and several other programs, I know they're working towards initiatives to hopefully get noticed so that we can change that, but it is a definite challenge. One of the patient qualifiers that we've been a little bit more lenient on now that the program is active, but still very much considered is high risk for readmission. So I don't know if anyone is familiar with the LACE score, but that is what we use up here. And any patient that has a score of 11 or higher is at significant risk for readmission. During the trial, I took only those patients that were listed as a high risk, my highest being 15. And that patient definitely was a bit of a challenge. Another qualifier to this is it true non-compliance or non-adherence that the patient is experiencing, or is it just a compliance challenge? In many cases, it's not that the patient chooses to be non-compliant just because they have some sort of a barrier, and it's often a barrier that they don't want to discuss with anyone else. So being able to identify what that is and how we can help, that has been a huge asset to the hospital and to the program. And this kind of falls into the next one, social determinants of health concerns. Yes, there's scoring available for nurses to complete, but let's be honest, patients aren't really going to tell you what the truth is if they're having some sort of a financial difficulty, or if they have some type of mental health issue, or if their support system is non-existent, if they don't have food in the house. That kind of stuff is very embarrassing. Chances of them saying yes to any of that in a hospital is slim, but you would be amazed at what people will tell a community paramedic in the home, for whatever reason that is. And then social work and case management notes. If there is a patient that they truly think could benefit from community paramedicine, we considered that as a qualifier, if they met everything else. So program navigation, this is specific to our program here in St. Clair County. I can't really speak for anyone else's, but I get a census from McLaren every morning, and we go through it together as case management and quality improvement. So my team isn't necessarily employed by Tri-Hospital EMS, but they are extremely valuable to the success of this program. After I receive the census and we discuss qualifiers and who meets what we would like to see, then I set up meet and greets at the hospital. So this was one of the trial initiatives that we implemented to see if it made a difference in who consented to be enrolled or not. And if they can put a face to what you're talking about, 9 times out of 10, they will consent to being a part of the program. So I do whatever I can to be able to meet a patient in the hospital before they're discharged. Sometimes it's not possible, unfortunately. But I would say 85% of our trial patients, I was able to meet that objective, and it definitely made a difference. Research and scheduling, I also do this with our McLaren team to dive in and hopefully isolate some of those issues I might come against. Sometimes the social work, their documentation it can be extremely helpful. Is this a patient that I might really not be able to help, because it is chronic readmission, and we've given them all the resources and tools in the world, but they just don't. They don't want to listen to it for whatever reason. Once we identify those patients, I will follow their case through the hospital until they're discharged. The hospital will notify me of their discharge, and then I try and contact the patient within 24 hours, not to see them within 24 hours. And I think that's a big component too, especially after a prolonged hospital stay. They just want to relax and be home for a little bit. It also gives them time to think of questions that they might have, or things that maybe they didn't understand. And then they can keep that list for me, and we can go through all that at the initial visit. Initial CP visits, I try and see them within 48 to 72 hours. 72, I don't really like that, but I'm not here on the weekends. And so if someone's discharged on a Friday, that makes it a little challenging. Initial visits oh my goodness, I'm so sorry. Consist of going through their discharge instructions and all their medications. There's a full med rec involved, which can take significant time during that visit. So those visits are typically an hour and a half, depending on the situation. And then our enrollment is weekly for those first 30 days outside of the hospital. So the goal that I have set up with McLaren is to hopefully reduce readmission permanently, but within those first 30 days especially. And we've seen very good success with that. Program completion is either successful based on goal met, or unsuccessful due to non-compliance, or the patient not wanting services after X amount of time before, the discharge readiness assessment would warrant them being released from the program. Meeting goal classifies as either successful discharge, so they met all their visits, they did everything that, we had set up for them, they did it well, and, they're free to care for themselves. They're pretty confident in doing that. They don't need me anymore. I mentioned the second one a little bit earlier, but transfer of care. So getting that patient where they actually need to go. If they need to go to hospice, great. If they need to go to a skilled nursing facility, facilitating that for them. Coordinating with home health care to get PT and OT if that's what they need. Wherever that patient needs to go, if I'm able to get them there, then that's considered goal met. And then any personal goal set by the patient or set by me, set by their primary care provider. We want to wean off oxygen. I don't want to be on oxygen anymore. If we can meet that goal somehow, then that's also goal met. So this is the fun part. This is our trial data. Quick stats. I saw 12 patients. 11 of those met goal. In those 12 patients, there were 45 visits completed, split among those. I had one unplanned discharge because the goals were just not met, and unfortunately, that was a true non-adherence issue. We dumped tons of resources into this case, and unfortunately, there was just nothing I could do. I did have one patient that we transferred to skilled nursing facility for higher care, and that is what they needed. The hospice patient that I spoke of early, that was a goal met. And then I did have 2 visits within those 45 that required emergency intervention and the activation of our 911 system. So once they got discharged from the hospital, we just resumed our visits, but unfortunately, those were not avoidable. So to give you an idea of some of the services, and again, this is just a very brief overview because there's quite a lot. Care coordination, home health care, PCPs, whether it's hospice, whether it's, I don't know if anyone's familiar with PACE, Sunrise PACE programs, but we've done some coordination with that. Medtronic for diabetic insulin pumps. I had a patient that was a hang up. He didn't know what he was doing. He didn't know how to figure that out. And so part of the visit was making contact and actually having Medtronic go through that. After that, we had no further issues with him. It was wonderful. Medicare, Medicaid navigation assistance has been a big one in our community. There are Medicare advocates that you can actually contact, and I had no idea until we started this program. They will help a patient go through their plans and explain what it is that they can ask for or what that plan will cover, and they've been a huge asset. Most wouldn't know that they even exist, let alone how to contact them. Home oxygen concerns. We've had patients that for whatever reason can't get portable oxygen or they can't get portable tanks. When they came home, they were supposed to have oxygen and there was a miscommunication somewhere. So we've been able to navigate that. Medication adjustments by primary care providers. If they want to pause on a medication due to signs and symptoms that I have found in an assessment, that's happened. Ambulatory assistive devices, that's, home healthcare as well, but just having extra eyes. Do they really need a walker even though they don't want to use it? Do they really need a shower chair to avoid this fall risk? I've done prescription pickups for patients. I've set up home delivery of those medications for patients. Whatever we can do to make it easier on them is what we try to do. The transportation concerns, there's quite a bit of PCP enrollment issues in our community. So a lot of patients that I acquire don't have a PCP for whatever reason. So most of what I do is trying to facilitate getting them enrolled with someone that can follow their care appropriately. This was a case, a recent case actually outside of the trial, and it's a beautiful depiction of what CP is capable of. The diagnosis in this case was new onset insulin-dependent type 2 diabetes. Had never before had issues with anything. He didn't take any medication before this. By the time I made contact with him to schedule his appointment, he was extremely frustrated. You could tell that he was very overwhelmed with what was going on. And so what did they tell you? Let me help you work through this. He had no discharge education whatsoever. He confided in me that he probably administered his insulin pen wrong because he was not shown how to do that. So he had to YouTube that. He didn't know how to check his blood glucose levels. They never explained the monitor to him or how often he should do that. He was doing his own research to do this. And the only thing that he really was told was that sugar is bad and carbs are bad. So the gentleman took it word for word and decided to cut out all carbs and all sugar out of his diet, and he was eating only meat. By the time I got there, the education portion of this took 2.5 hours. We went through everything that I could possibly find to educate him, including teach back methods. By the end of this, he told me, well, I'm really glad that you came because I still wasn't able to get my glucose where I wanted it to be, which I thought was, outside of the 300s. And so I was just going to give myself extra insulin tonight and see what happened. So in this particular case, his PCP visit was scheduled for 3 days post-discharge. And the same day I ended up seeing him, his PCP had canceled that visit and rescheduled for the following week. He would have gone a week without any knowledge at all about what he was supposed to be doing, aside from YouTube, thank God, in this case. But the summary altogether, the visit was 3 hours. I sat down with him and his wife and explained, again, everything that I possibly could. I had a diabetic educator that I met with before this case, knowing what I was getting into, so that I had resources to give this person. The wife had told me afterwards, I was so scared when he got discharged. We didn't know what we were doing. And she said, now this doesn't seem so bad. So it has been 3 weeks, 3.5 weeks now, since diagnosis. He is more confident each day in what he is doing. We are working on getting him a CGM for continuous glucose monitoring, which will help him greatly. His glucose levels have finally begun to normalize, and it's very rewarding to see that. His diet has improved. He is very dedicated to doing that. He's handling the adjustments and medications well. Between the Lantus insulin and the metformin, he understands how they work in the body, why it's important. He now went from twice-a-week visits to bi-weekly visits. He is scheduled not only with frequent follow-up with his PCP, but he had his first ophthalmologist visit because that was recommended by me. And he is now scheduled to see an endocrinologist. And that doesn't occur, unfortunately, here for several months, but we're working towards it. So he is my success story for this round. I'm looking at discharging him on the 4th of February. So these are very hypothetical numbers. I'm just going to throw that out there. But this is as close as we can possibly get to what reality would be for our trial summary. So I had a total of 45 CP visits altogether, and we charge $500 a visit for the CP side of it. So altogether with those visits, it would have been roughly $22,000 and some change. General hospital admission, especially if it's within those first 30 days post original discharge, is upwhere near 15 grand. It can be more, it can be a little bit less. It just depends on what that diagnosis is. So the last component to this is my 12 high-risk patients. If they were to have been readmitted, all 12 of them, which isn't likely, but I had some very significant patients that would have readmitted multiple times. There is no doubt about that. So if we take those 12 patients and we times that by 15 grand for the admission, it is approximate that we could have saved McLaren over 180 grand. So there's a little fact at the bottom of it. Readmissions in the United States healthcare system, they cost more than $26 billion annually. And $17 billion of that is Medicare alone for unplanned hospital readmissions. That's pretty significant. So some of the successes that we have seen in our trial, there's only one way to really find out if you're ready to go, and that's just doing it. So the success has large-handedly been the patient satisfaction. Not only do they really value that extra education, but it's just that reinforcement. So even if it's something that they were told or kind of remember from discharge or their hospital stay, they're like, oh yeah, like I remember someone telling me that. And then that gentle reinforcement throughout our visits has been so crucial to that satisfaction. Increased health and medication literacy. It is very rewarding to explain to a patient this is why they want you to take your beta blockers, because this is what it does in the body. You need that. And if you can explain it in terms that they understand, just the light bulb that goes off in their head and being able to watch that, it's really something else. Smoother care transitions for patients. Wow, that wasn't so bad. I was really overwhelmed at discharge, but on, visit 2 with you, I really think that I can handle this on my own. This doesn't seem as intimidating as it was. An increase in quality of life. So whether that be my hospice patient, the first time I saw her, I was able to keep her out of the hospital for 30 days, which previously had not happened in quite some time. She was readmitted and ended up coming back to my program and eventually being a transfer of care. So overall, to watch her go through that, we got her what she needed. And that was very rewarding. Collaboration with other agencies, this has been such a huge success for us, and it was in the trial as well. Once you can explain what it is that you're doing and that it's not just a rogue procedure, we have protocols that we have to follow. There is documentation requirements. I'm not just out there treating your patients willy-nilly and, scaring everybody. The physicians become very involved in the program and they are very excited about it. And to be able to open that communication to everybody in the healthcare team, the patients just get better care overall. And then the opportunity for public education. I love educating. I love being a part of that. And it not only goes towards the public, because I end up educating family members and friends too. We invite everybody over sometimes, but they can pass that information on. And that's really nice about this as well. And then, of course, the integration with the 911 system. It's very valuable. Some of the hurdles. And the first one is capitalized because this is for every CP program. This is not just for me. Funding and reimbursement challenges are so depressing when it comes to doing this. Everybody loves the program, and there is no doubt about it that it works, but nobody really wants to pay for it. And so ultimately, the patients suffer for that. navigating the scope of practice kind of goes hand in hand with the lack of standardized training that I have a little bit further down on the slide. It's very difficult to get reimbursement and funding for a program that isn't totally standardized yet. And we're getting there, but especially in the state of Michigan, they don't know what they want for standardization yet. And so until we see a standardized curriculum or a standardized protocol set so that we can validate what it is that we're doing in the field, unfortunately, I think we're going to continue to see some of those funding and reimbursement issues. There is a potential for service duplication, even though we are very heavy on trying to not do that. Sometimes inevitably we are doing similar things to other agencies. So being mindful of that and communicating with the other healthcare entities in the community, I think that's very vital. You don't want to step on toes, but you really need to help each other in order to make this work. And then public perception overall. What is it that you do? I noticed that your name tag says community paramedicine. Can you tell me about that? And we often find that in the public eye, they don't know what a paramedic does on a good day. So to introduce them to what a community paramedic does, there's some significant education in that. And once they understand, it's just, oh my gosh, I didn't know that you could do this or this. So that's been huge for us as well, is increasing that exposure. So this is a snapshot of where the program is today. So it relaunched with a contract with McLaren Port Huron as our main patient referral source in early January. My first patient that I saw was on January 10th. So this is all very new data. The program here operates Monday through Friday, 8 to 5, within reason. I do have a CP hotline number that is active, and that has been a really big help when it comes to who do I call, what do I do after hours. So this hotline it goes right to our Med Connection program that we have here at our central location. It's always answered by a human, which has been the big factor to most of my patients. They always get to talk to a person, and they have a protocol that they follow that was written out by me when we were building the foundation. So if it's an emergency and they really need somebody, then it just gets transferred over to our central dispatch, and we dispatch an ambulance. If this is something that could wait to the next business day, they'll just email me, text me, or if it's a question that really should be answered and is urgent but not emergent, they'll just page me and I can call the patient back. So that's been very helpful. It is still COPD, CHF, AMI, and diabetes. Again, I don't see much sepsis. It's not that it isn't here. It's just that the first 4 in our community are an overwhelming population that really needs some help. So that has stuck true. My 2025 quality goal with McLaren Port Huron is to reduce high-risk readmissions overall by 1%. And while I think we're going to exceed that, and I love a good challenge, we set the goal at that, just to see how far we can get with that. Additional CP staffing and training is underway here. We are trying to launch our own community paramedicine program so that we can teach our own people and hopefully a lot quicker to get some help on the road. That might take just a little bit of time to orchestrate how we're going to do that. And it says 10 active patients, but as of today, I have 12. And then my very first patient that I took on, he'll be the first discharge on the 4th of February. So this is just kind of a closing remark. It's something that I really value and I hold dear. Paramedics are extremely knowledgeable in a vast capacity that most people are not aware of. We know a little bit about a lot of things, but if you can incorporate that chronic care education aspect into it, and increase knowledge in pharmacology, an increase in how to keep a patient home and take them out of that mindset of I have to transport a patient, this is going to be the future of healthcare and the future of community paramedicine without a doubt.
All right. Thanks, Amanda. That was really great. I think we do have a few questions in the chat. So I'm just going to go back here and look. Looks like Emily answered one of them.
I think our most recent question was from Stacy Karowski, wanted to know, while Rachel's looking, I'll just jump in.
Okay.
Wanted to know how many CP staff you have. How many is it just you?
So that is an excellent question. And as of this very moment, it is just me. So I oversee, manage, and perform the daily operations of our community paramedicine program, which is a lot. But because the education is so extensive, and I'm the only community paramedic certified in the county, I can't just take paramedics off the road to fill those spots. So that complicates a lot. We would see a larger volume of patients without a doubt if we had even just one more part-time community paramedic, but that's coming. That is coming.
Great work, Amanda.
We've got another question from Kelly. How do you communicate between hospital and PCP? Do you use an EMR?
So we use to document in on my side, we use Mobile Touch Health EMS. It's a platform widely used by EMS. It's not a living document, so there's definitely some hurdles with that. And it's one of the biggest challenges in documentation for me is being able to document in real time. So I do have access to McLaren's software at this point. So a lot of the patient research I try and do on my own if I can. Diving into the diagnoses, I can read all the progress reports, I can see all the labs, I can print the discharge summary prior to visit. So I can really look into, are you following it? Are you really doing this? Because this is what the piece of paper says, and you were actually prescribed that, so don't blow smoke, I do my homework before I meet these patients, and I can't unfortunately document in their charting system. There are some programs that allow that. Anybody that uses Epic for their CP programs, I'm jealous. They can actually put notes right into that chart, and so everybody can see that, and I cannot. So what I do is I document my visits as I normally would, and then I go on the back side and the administration side of our documentation, and I save all of those reports. And I don't know about anybody else, but our physicians, they still utilize fax machines for the most part. So I don't have a choice but to fax this documentation to our primary care providers. And then what they choose to do with that afterwards, I don't have any control over, unfortunately. We do recommend to them that they put it in the patient care record, and if they, would like to reference that further, they're welcome to do so. But it's just the state requirement that it gets where it needs to go. So.
We do have another question from Gail. Are you aware of any other working programs in the state?
So in the state of Michigan, there's 12 right now. And some programs you'll find if you research them a little bit, they're more MIH than community paramedicine, but they've used that term interchangeably. So some programs operate more just education based, and they don't carry like a separate drug box like I do. They don't have protocols like I do that I can actually intervene and give IV Lasix if I needed to, or give an antibiotic for a UTI if I need to. That has helped quite a bit. One of the very first programs in the state, and they are the gold standard of community paramedicine. Everybody wants to be HVA. HVA, JCA, they have a wonderful program over there. And they actually have two. One is integrated more with their 911 system. And so they actually do triage within their 911 system. If a call comes in that doesn't necessarily warrant an ambulance, they'll send their CP instead, which is a model that works for a lot of agencies. We have not done that, at least not yet. The other portion of the program deals with nursing facilities quite often. So they start their IVs, they start their catheters for them, they draw their blood, and then they run echo as needed. So there's lots of different models of community paramedicine programs, and I think that's what I enjoy the most about it. The versatility, the flexibility, it's infinite. So.
All right. Well, thank you, Amanda. I think we're going to have to move on because we have a couple more things to cover. Thanks, everybody, for all the great questions. I did have some discussion questions that I was, hoping maybe people could answer, but I think we've had plenty, and the, discussion's been really great in the chat. So we're not going to worry about that today. If you do want to answer these questions in the work group survey, I do believe that there is a section in there that you might be able to put in some extra information. Just going to move on to what we have coming up. We have some upcoming work groups in February. Our next one will be on Tuesday, February 11th. That'll be our first cardiac rehab work group. And this will be led by Dr. Stephen Catane from Henry Ford Health. He will be speaking on his hybrid cardiac rehab program. And then following that will be a health and action work group on Thursday, February 27th. And that will be actually with our own MVC's Janice Stewart. She'll be presenting on part 2 of the patient journey mapping process that was a part of the breakout session she led at our fall collaborative wide meeting in October. So if you've missed any of the work groups, just so you know, you can read the highlights in our January work group blog. And that will be coming out next week, the first week of February. So keep your eyes open for that in your emails. And then upcoming events, most of you should be aware, but just in case you aren't, the MVC process measure reports are out and they are available in your Dropbox. If you do have any trouble accessing your Dropbox, please let us know. You can give us an email or send us an email to the Michigan Value Collaborative at med.umich.edu. The P4P final scorecards for those who are doing the P4P program will be coming out in Q1. The final send out date is still to be decided, but that should be coming soon. And then finally, our MVC Spring Collaborative Wide meeting is going to be Friday, May 9th. So mark your calendars. We are currently looking for presenters for this collaborative wide meeting and then also our work groups throughout the year. If you're interested in doing a presentation, we do have a presentation proposal form. The link is available on our website on the events page, but it will also be in the slides that we're going to be sending out to you guys later today. And just for you all to know, we are looking for presenters who have something that they might be able to share with healthcare collaboration between hospitals and physician organizations or other healthcare entities that might be really interesting for our members to hear about. And with that, the post-work group survey link should be in the chat. Thank you everyone for joining us today. And remember that if you are filling out the survey for P4P credit, please only select one hospital that you're attending on behalf of today. Thanks again and have a great rest of your day.